If you're a healthcare professional interested in ultrasound-guided foam sclerotherapy for the treatment of superficial venous reflux and varicose veins in the leg, you're in the right place. Today I'm going to discuss ultrasound-guided foam sclerotherapy with a world-renowned expert, Dr. Chris Pittman. We will discuss how we make foam, how we inject the foam, how many sessions are required, how to avoid brown marks, and how to position our patient.
This is me. These are my disclosures. I frankly think disclosures should stay up the entire time a person is speaking. I do think this disclosure is important. I have been an administrator for foam sclerotherapy experts for many years now. We're approaching 1,500 worldwide physicians. I search the world's literature on foam sclerotherapy and some other topics every day. I look at these articles. If I think they're of merit, I post them and make comments. And we use mid-level providers, physician assistants, and nurse practitioners work in concert with an ultrasound technologist and can do foam sclerotherapy just as effectively as I can, and they can do it just as safe as I can. And my colleagues Rob Worthington-Kirsch and President-elect of AVLS Satish Vayavegala presented several years ago their experience at Vein Clinics of America of comparing physicians to mid-level providers and an ultrasound technologist, both basically the effectiveness of foam. Well, actually, to be more accurate, the safety, and there was no difference. So we use 1% polydocanol. We don't use compounded sclerosant. I don't work for a Sclera or Kreuzler, but we use the non-compounded FDA-approved sclerosant at scale. We use 0.5 milliliters of 1% polydocanol mixed with 2 milliliters of room air, ready to go with a 3-way stopcock, and it generates 2.5 mils of foam. We typically give 10 cc's, 10 mils of foam, but we don't have a hard rule about that. We might do a little less, we might do more, depending on burden of venous disease. Room air is definitively more stable than any physiologic gas, and that's why we prefer to use it. Technique is more important to safety than how foam is made. Small repeated injections using freehand ultrasound technique, in my opinion, is more important than large foam aliquots using butterfly needles and other things. A reluctance to put a needle in a patient as many times as necessary to do foam contributes to the problems with foam, the ineffectiveness of foam, so-called phlebitis, and pigment. Those who are unwilling to poke their patients with a needle as many times as it takes are doing their patients a disservice. As an interventional radiologist, we work on awake patients. My entire career, we have to be pretty good at anesthesia. We never use lidocaine when we inject foam through a 25 gauge needle. We simply pop through the dermis very quickly. Our nerves sit right there under the dermis. If you go in nice and slow, you will hurt people. Do not under-inject. Way too many practitioners confuse injecting foam with implanting foam. I'm going to quote Kourosh Parsi and his team, David Connor in Sydney, Australia. I consider them to be foremost experts in both the clinical aspects of foam sclerotherapy and the basic science aspects of foam sclerotherapy. And Kourosh talks about implanting foam. You don't inject it. And I think if you think that way, you will do much better. Unfortunately, I found many of those who perform foam don't understand or don't appreciate that the sine qua non of adequate foam injection is complete venous spasm. Injecting foam into a vein and watching it swirl around is not foam sclerotherapy. You must get complete venous spasm. And you must be willing to inject via multiple punctures. We don't believe in catheters or butterfly needles in our office. I'm not saying they're wrong. I'm just saying they're not as good as how we do it. As I previously mentioned, you have to be willing to inject, re-inject veins, and have absolutely no hesitation in the when you feel like you need to do it. We use a 25 gauge venipuncture needle. I do it freehand. I'm an interventional radiologist, so I suppose we're pretty skilled at this stuff. We have a medical assistant, or really anybody, it doesn't have to be someone, it could be your front desk person. We call them a foam barista. They are creating the foam for me, and they hand me the 3cc Terumo syringe when I'm ready, so I can rapidly and readily inject the foam without fumbling with making foam before I get in the vein. So the moment I'm ready to puncture that vein, the foam barista has the foam ready. They hand it to me, my needle's in the vein. Because I'm freehand technique, I do not aspirate. I don't need to aspirate. I can see the tip of my needle in the vein. It's not a problem. I then inject the foam. I would further say that I think there is too much concern about extravasating foam when you use 1% polydocanol foam. I don't know about those physicians who use 1.5%, 3% Sotradecol foam because they feel compelled to use much stronger concentrations of sclerosant. So I can tell you thousands and thousands of cases extravasating 1% polydocanol foam in our hands is of no consequence. You might discolor the skin temporarily or for a few days, but we have not had any resultant ulceration or tissue death problems from extravasating some 1% foam sclerotherapy made with room air. So I think there's some over concern for getting foam extravenous when we're doing foam sclerotherapy. I'm not saying be sloppy. I'm just saying it's almost a needless concern. So my ultrasound techs and my physician assistants arguably do foam better and sit more safely than I do, because the ultrasound technologists hold the transducer. We don't do a transverse approach, we do a longitudinal approach, which I think it's good to be skilled in any method, be it axial or longitudinal, when you're doing imaging guidance. But when it comes to injecting vessels, I strongly urge people to do it in the longitudinal plane. So our ultrasound tech will hold over the vein, the target vein, in longitudinal fashion. The PA will make their own foam. They will next put the needle right at the foot of the ultrasound probe and direct their needle quickly through the dermis, as we teach them, and into the vein. They are able to aspirate, get a little bit of blood in the hub, and then inject. This works fine. I do understand that worldwide that there aren't ultrasound techs everywhere, and that mid-level providers are limited through licensure and other things in other parts of the world, but in any case, that's what we do. Do not under-inject. You must get complete venous spasm, and that includes a perforating vein, which we routinely inject large perforating veins, close them, and we don't have DVT. 2 or more sessions. There are too many practitioners, Haroon, who have I don't know, when I was in the hospital, surgeons used to say, well, you know, I'm going to fight another day. I'm sorry I can't see your face. You know, sometimes, you know, the surgical case, you know, would be so tough, they close them up and they bring them back another day. Well, I would say when it comes to foam sclerotherapy, you must fight another day. If you don't, you're doing your patients a disservice. So you must do at least 2 foam sessions per leg. Why? Because I don't care whether you got complete venospasm, even if you got complete venospasm in every vein that you saw on day 1, the next day or the next few days or a week later, you will re-ultrasound these patients, because we've done it for a long, long time now, and find veins that you had no idea you overlooked. It's like, what's going on? My own personal belief is that many veins spasm as you incrementally inject foam that you're unaware of. And you will come back the next day and be completely surprised at the number of tributaries and other veins that you meticulously overlooked the day before. That's one reason. The other reason is we understand, or we should understand, that when we inject foam, Tessari published on this, it's gone in 8 seconds. It's no longer biologically active. And so I find many practitioners obsess over foam in the deep system when it's not doing anything anymore. Again, the sine qua non would be spasm. I get foam in the deep veins routinely, but it doesn't lead to spasm and thus, you know, deep vein sclerosis. I'll get back to deep vein sclerosis, a term coined by Parsi and his group that's extremely important to cover. So you will overlook veins if you don't come back a second time. They may be in spasm. And my point about pointing out that in 8 seconds the foam is gone is, as you're injecting foam into a vein, you get spasm. But at some point over that 8-second time period, as the foam travels, it obviously gets less and less effective because it's being simultaneously consumed by the red blood cells. So at the leading margin of your foam, and I think we all fundamentally understand this in our mind's eye, the foam isn't that effective. And Haroon, I wish I could see your face, but that includes your 3% foam, your 1.5% foam. I don't care what concentration you make. As it travels and over time, it becomes less and less effective. You could use 10% foam, and this concept is operative anytime you're injecting foam. So because of this, you will see veins that I fear some colleagues say, oh wow, I see foam in the vein, I'm done, it looks great, you know, I don't need to do anymore. You will come back the next day and you will find areas that you thought you foamed that are perhaps not completely open, Haroon, but are partially closed or not completely closed. And that is the root of problems with phlebitis and pigment. People who undertreat their patients with foam sclerotherapy are literally creating SVT. They're creating it. And they're getting all the results of an SVT, which is a lot of pain and a lot of heartache. Let me go on to the next slide. Inject foam into partially closed veins. I've heard everything under the sun. There's so much lore, not just in medicine, you know, just because we've always done it that way. And I was told, and you know, they're still telling people to make a wheel when they do lidocaine. Yeah, if you want to hurt the crap out of people, make a wheel. How about stick your needle through the dermis, inject lidocaine, in the subcutaneous fat and pull it out slowly, and you're going to hurt your patients a lot less. But still, it's taught in medical school. Make a wheel. I haven't done that in decades, and you will hurt people less. Sorry for that digression. The need for I&D in our office is extremely rare. I'm not making this up. I might have to do it once every 2 months because we're very aggressive at re-injecting what we term spongy veins. So when you come back the next day, the next week, the next month, okay, we inject spongy veins, or many of us will see a filling defect in that vein. And so we will inject more foam. By golly, the best time to inject foam, arguably, is when it's partially closed and has a coagulant or filling defect in it, Haroon, because then your foam is exclusively limited to the intima of the vein and the filling defect. I hope that makes sense. So one of the best times to inject a vein is when it's partially occluded. You can direct your foam where it needs to be because there's a filling defect already in the vein. So phlebitis is the result of partially closed veins, and physicians who have this one and done, we're not going to fight another day mentality. To fully understand foam sclerotherapy, treat SVT with foam. Oh my God, that's crazy, Chris. It's not crazy. Actually, there's other practitioners who come up to me, oh, I've been doing that for years. The only difference is they're not as loud as Chris Pittman. So I so enjoy your forum, Haroon, and look forward to its future because we can share among believable high-volume practitioners and advance the field of venous and lymphatic medicine on behalf of patients worldwide. So that's right. If someone comes in with an acute or subacute or chronic SVT that is symptomatic in any way, we will inject foam into that vein. And guess what? They'll be out of pain within 24, 36 hours. This is also fundamental to understand. Intact intima on an ultrasound indicates that the vein needs more foam. I'm sorry I don't have any pictures to share, but I'm happy to do that in a follow-up. But it is pretty easy to identify on ultrasound, Haroon, an intact intima versus one that has been adequately impacted by foam. I'm bombastic a little bit just to get people to think. That's it. I'm not trying to stir the pot, but you actually don't need to excise a vein, look at under a microscope, and do all these different things. You can actually see on ultrasound whether the intima has been adequately treated with foam. And in the vast majority of partially treated veins, you will see an intact white line intima that everybody should be familiar with who does foam. So intact intima on ultrasound means more foam, please. If you kill the intima, you kill the vein. If you kill the queen bee, the entire hive dies. I'm sorry for the analogies. Not all of them are good, but they help me understand things. So if you injure the intima, as occurs, actually with SVT, Haroon, the intima isn't injured at all. There's merely a thrombus. And the thrombus and the physiologic response to thrombus and the whole act of trying to recanalize that clot is what hurts the patient. So what many of my colleagues do is they create SVT and they get in this they get in this flywheel of IND and, I got to drain the vein. No, you need to inject more foam, please, and kill the vein. So we fight fire with fire all the time. Patients come in, oh my gosh, I got foam and I hurt. Great, we're going to inject more foam right into it. We're going to fight fire with fire. And by golly, the pain will resolve over a day or so, with compression and possibly some non-steroidals and over-the-counter pain medicines. But this concept of if you injure the intima, the vein may kill the patient. And by that I mean they're going to hurt. They're going to hurt. And if you want to, I think the best way really to understand what I've said over the last 3 slides is to actually inject foam into SVT. The only difference between de novo, off-the-street SVT and what we do as foam sclerotherapists is we kill the intima of the vein. And when you kill the intima of the vein, you stop the physiologic process that leads to the pain. So I'll quit beating that horse. Spongy veins are injured veins. Put them out of their misery. Sorry for the horse lovers, but the analogy we use is a horse behind the barn, and we need to go put it out of its misery. Let's inject more foam into it. Next slide. Persistent pigment means partially closed veins, 100% of the time. Now, persistent pigment. I hear this, oh gosh, Chris, what about phlebitis? Well, we already covered that, as if it's a complication. For God's sakes, tenderness is expected after foam sclerotherapy. Again, you've got to manage your patient's expectation. It's like tenderness is discomfort when you touch the leg. Pain is discomfort when you're standing around. Pain and tenderness are 2 completely different things. And we tell every patient, you will be tender, 100% guaranteed. It is not a complication. It is an expectation. And if you talk to your patients that way, and you fully treat the vein, they won't progress to pain. So pigment works the same way. Pigment is an expectation. If a patient doesn't get pigment, you can celebrate. But I tell every patient we want to under-promise and over-deliver. You will get tender, you will get pigment. If pigment persists or gets worse over 3 to 4 month period of time, 100% of the time a vein is open either beneath the pigment or beneath the vein or around the vein. Closed veins, don't trust your ultrasound tech. Now I'm being provocative for fun. On ultrasound, veins can look closed all day long. But they're usually not completely closed because we routinely inject foam into thermally ablated veins. Days later, weeks later, months later. And you will be shocked at the foam that goes from that I inject at the knee in a GSV that travels, Haroon, all the way to the saphenophemoral junction. Look at foam as an angiographic agent, and it will teach you a lot. So if I see pigment if we see pigment in our office that is persistent or worsening, we will do a meticulous look with ultrasound, and whether I think they're closed or not, in many cases, I will inject them. The only way you'll know is if you actually inject these so-called closed veins. When you do that, your pigment will start to regress. If you have these partially closed veins in and around an area of pigment, you have a water hammer effect that does not allow the white blood cells in the area to consistently or win the battle of taking the hemosiderin out of there. And once you eliminate that water hammer effect, the white blood cells have a chance to take the iron away. And I would use this analogy clinically, if you will. When we see hemosiderotic pigment in a lower extremity, it's obviously because blood is leaking out and staining the skin and hemosiderin deposits. But once you stop that feedback, where the deposition of iron in the tissues has overwhelmed the ability of the white blood cells to take that iron away, then the pigment improves. We all know it may not go away completely. In fact, it usually doesn't. But at least in our hands, it usually improves. So I'm using that example, Haroon, to back up the concept of persistent pigment means partially closed veins. I like to treat patients supine. There are plenty of articles saying compression and elevation, all these things really don't make a whole lot of difference. We could argue about exsanguinating the vein being a better situation, but again, that depends on practice context, as we've talked about off video. So I'm going to point out one more physiologic thing about foam sclerotherapy. Since we all agree, Haroon, that the sine qua non of adequate foam sclerotherapy is complete venospasm, then we have no difficulty understanding as we inject foam in superficial veins and foam starts to stream across perforating veins, that perforating veins will not close until they spasm, okay, by definition. So as you're injecting adequate amounts of foam in the superficial veins and it starts to stream across the perforating vein, whether you're looking at it or not, the vein will start to spasm and ultimately limit the amount of dangerous, I'm using that in quotes, foam going across the perforating vein. It's actually protective. The mere act of venospasm that occurs when you're injecting foam protects the deep system if you're getting adequate amounts of foam across the perforating vein. Here's where people get into trouble, and this is informed based on experience viewing real-time lower extremity and performing countless of them, lower extremity venograms. We actually do have a calf muscle pump. We actually do have sinuses in the calf. It's literally a little heart. And when you drive contrast agent into the deep system, you will see stagnant contrast-laden blood in sinuses of the calf, or so-called gastroc veins, which is why I advise everybody to not over-inject if you're a beginner below the knee. Below the knee, do 0.5 ml aliquots of foam at a time. I think it's a good idea to activate the calf muscle pump, have the patient do that for 5 seconds post-injection. I won't get into the nuances, but if you want to stay out of trouble, do that. You have to do that to drive any foam that is stagnant, even for a few seconds, out of the calf muscle pump. That's why I advise that. Now, at the knee and above, inject all you want, Haroon. It doesn't matter. If you watch a lower extremity venogram, you will see the speed of flow in the femoropopliteal system so fast that there is literally no way you can inject enough foam. I mean, if you're really stupid, you really try hard, maybe, but even then I kind of doubt it, honestly, because we know that the sine qua non is complete spasm. And it's going to be hard for you to get enough foam in the fast-flowing blood of the femoropopliteal and certainly the iliac system to achieve complete venospasm, which is why you can inject 2, 3, 4 cc's anywhere above the knee and you're going to be fine. Parsi and Connor talk about deep vein occlusion. They looked at nearly 10,000 cases over 6 years and found a deep vein occlusion rate of 2.8%. They subjected these deep vein occlusion, they didn't call it clot or deep vein thrombosis, they didn't call it deep vein sclerosis, they called it occlusion. They subjected these patients to D-dimer, to a D-dimer test, and determined that the number of DVTs was 0.07% based on positive D-dimer, and deep vein sclerosis was 2.74% out of a deep vein occlusion rate of 2.8%. So the vast majority of so-called DVT that they found, mostly in the calf veins, as we've already covered, Haroon, was actually not DVT. It's a very interesting term, deep vein sclerosis. So they used up to 21 milliliters of foam was used per session. So I would say that the rate of actually in their clinic, the rate of DVT is so low at 0.07%, they don't do ultrasound follow-up anymore. I mean, this is a seminal paper, in my opinion. It should inform all of us that foam is not as dangerous as most people make out to be. They are under-injecting their patients. They needn't do that. And I guess I will conclude with this. I think many people are probably over-treating. No matter who does the treatment, me, you, anybody in the world, one and done is never going to completely treat that patient 100%. I don't care if you're doing glue. I don't care if you're doing thermal. You're going to have some failure. And the ultimate safety net is foam sclerotherapy. So you've got to be willing to see these patients again and create a masterpiece. All right. Thank you, Haroon. Only foam, ultrasound guided foam, can meet the needs of our patients over their lifetime. Thank you.